Good morning, everyone. Comprehensive genomic profiling has powered the precision medicine revolution in oncology. We are now selecting from a broad menu of therapies based on the individual tumour signature. And of course, there's an even larger number of clinical trials underway to develop new therapies and new combination therapies. But comprehensive genomic profiling, or CGP, does have its limitations. Turnaround times have increased, weeks to sometimes months, in a patient population that doesn't have time to spare. Our QNS rates have increased, sometimes up to 1 in 10 or 1 in 5 patients not getting a mutational analysis, not getting a molecular analysis, allowing them and not allowing them to go on to approved therapies that are known to be effective. And last of all, cost remains a barrier to access. If we can harness the power of CGP whilst overcoming its limitations, then we can deliver precision medicine to all cancer patients in the future. My name is Darryl Irwin. I'm the Vice President of Scientific Affairs at Agena Bioscience, and it's my pleasure to welcome you today and also to introduce our speaker, Dr. Jessica Thomas. Dr. Thomas is the Associate Medical Director at the Houston Methodist Hospital Pathology Diagnostic Laboratory, and is also an Assistant Professor of Clinical Pathology and Genomic Medicine at the Institute of Academic Medicine at Houston Methodist Hospital, and an Assistant Professor of Clinical Pathology and Laboratory Medicine at Weill Cornell Medical College. Dr. Thomas has an amazing biography that would take me half of this session to go through. So I'm not going to do that because we want to hear what she has to say. So welcome, Dr. Thomas, and thank you for joining us today.
Thank you very much for that kind introduction. I appreciate it. Hi, everyone. Thank you for coming today. I'm Jessica Thomas. Today I'm going to be talking about rethinking solid tumor profiling and how we have used complementary technologies at Houston Methodist to guide better treatment decisions for our patients. All right, so I have no conflicts of interest to disclose today. And what I'm going to be talking about mainly is our reflex-ordered testing in lung adenocarcinoma. This is part of a larger initiative at Houston Methodist to standardize molecular biomarker testing for oncology. So first I'll do a little bit of background, and then talk more specifically about our reflex-ordered testing strategy, talk about the workflow and the platforms that we use, and then some outcomes and experiences that we've had. So I think everybody knows that molecular testing is essential for oncology patient care, and assessment of actionable biomarkers that have predictive and prognostic utility is now the standard of care for many different solid organ tumors. So these molecular biomarkers can be utilized to determine chemotherapy regimens, what's actually going to work for the patient, specific targeted therapies, immune checkpoint inhibitor use, targeting of DNA damage repair pathways, and resistance to specific therapies. Some examples of predictive molecular biomarkers in solid organ tumors. For non-small cell lung cancer, of course, EGFR and ALK can both be used to determine a patient's response to targeted therapies. In melanoma, you have BRAF and KIT to determine response to small molecule inhibitors. For colorectal cancer, especially metastatic, you can be looking at KRAS and NRAS to determine whether a patient is going to be resistant to your anti-EGFR therapies. For breast cancer, ERBB2 or HER2 gene amplification can determine responses to monoclonal antibodies and small molecule inhibitors. For BRCA1 and 2, that can help determine response to PARP inhibitors, etc. So the landscape of molecular biomarker testing in solid organ tumors has become increasingly complex, and the testing recommendations seem to change very frequently. And you have to keep up with this because there has direct implications for patient management and therapy. So at Houston Methodist, we were confronted with this and asking ourselves, the rest of the medical staff, hospital leadership, how do we ensure that all of the appropriate patients receive the recommended testing? And can we standardize these ordering practices? We really need rapid turnaround times for these molecular results. Weeks and months is not good enough. And so this has become increasingly critical to guide therapeutic decision-making and time to treatment. So how do we improve these turnaround times and improve our laboratory workflows? So fortunately, at Methodist, we had a variety of different methodologies and platforms that we could use to perform the testing. And it was about making the decision of what we were going to use because there's advantages and disadvantages depending on the specific alteration that you're talking about, the specimen types, and the sources that you're receiving. So we began an initiative of reflex ordered testing at Houston Methodist. So essentially the way that this works is we have an approved panel of specific molecular biomarkers depending on the pathologic diagnosis. The pathologist orders these at the time of diagnosis, and it's all agreed on by the medical executive committee, by the medical staff as to what specific biomarkers will be ordered at the time of diagnosis. And our goals were to standardize the molecular biomarker testing that we were performing and also to improve our turnaround times to molecular results. So these are some examples of the approved reflex ordered testing at Houston Methodist currently. So we have a lung adenocarcinoma, all new diagnoses, and that's what I'm going to be expanding on for the rest of the talk. We do also have for colorectal cancer and endometrial cancer, Lynch syndrome screening, which is reflex ordered. For advanced stage colon cancers, we do BRAF and RAS mutations, new diagnoses of melanoma, BRAF, and then for advanced stage ER-positive breast cancers, PIK3CA. So we are continuing to expand the reflex testing that we do in-house. So I'm going to focus on our lung adenocarcinoma panel. So again, this is pathologist ordered at the time of diagnosis. We implemented this in 2017. Okay, so this is ordered on the initial specimen for all newly diagnosed lung adenocarcinomas, regardless of the stage. So we don't wait for staging. We go ahead and order the reflex panel. We rolled this out to all of our system hospitals. So there are 8 hospitals in total in the Houston Methodist system, incrementally over the year of 2017. The adoption of this process did take time. We had to have medical executive committee approval at every one of the hospitals. We had to do physician education at every single one of the hospitals, and sometimes had to go back to do additional rounds of education, particularly to the pathologists, but also to the oncologists as well. The success of this initiative required the ability to actually utilize diagnostic tissue specimens. And so sometimes this is resection specimens, a nice big piece of tissue, sometimes just cell blocks or smears. And so we had to validate whatever process we were going to use on each of these types of tissue specimens. All of them were FFPE as well. These are often small fragments of tissue, and I'll show you some pictures coming up. Many of them have low cellularity and low tumor burden. And so we had to be careful about which platform we were going to pick in terms of the performance. We had to have the ability to accommodate increased testing volumes as well. And we needed to in-source single gene and or NGS methodologies for the detection of recurrent gene mutations and translocations in lung adenocarcinoma. So this is our reflex-ordered molecular biomarker panel for lung adenocarcinoma. And we started this in 2017, so that's before all of the new recommendations. So many of these were not actually recommended at the time, but our oncologists were quite savvy and understood that we needed to go for the whole panel. So this includes EGFR, BRAF, KRAS, ERBB2 gene mutations, ALK, RET, ROS, NTRK, and MET gene rearrangements, and then also PD-L1, IHC. So right now, the recommendations stand as EGFR, ALK, and PD-L1 are Category 1 recommendations. Everything else on this list is either Category 2A or recommended as part of broad molecular profiling. So how do we do this? We have, once we receive a diagnosis of lung adenocarcinoma, the pathologist will order the reflex panel. The sample is going to be FFPE, a tissue resection specimen, cell blocks, or smears. We do the unstained slides for molecular testing first. So in molecular, we will receive an H&E, and then we also receive 10 micron unstained slides for the testing. Unstained slides are also cut at that time for PD-L1 by IHC. And then we also do for MET gene amplification a send-out. We don't actually do FISH in-house, so that's the only send-out portion of this reflex-ordered testing. So once we have our slides in molecular, we do pathologist review. So we review every case for adequacy and for tumor burden. And we will do macro dissection if needed. And so you can see some examples of the slides that we receive. So on top there is a nice resection specimen, lots of tissue with pretty good tumor burden. And in those, what we would do is scrape 5 slides to extract. On the bottom there are smaller cell blocks, which you can see, very small pieces of tissue. Some of them can be around 50% tumor burden, some of them are lower. In those cases, we will extract all 10 slides, or we'll scrape all 10 slides to extract. Okay. From there, we extract total nucleic acid. And we do a process of quantifying DNA. For the DNA, we're actually using the IPLEX HS lung panel on the MassARRAY instrument. And the gene mutations specifically in that panel we're looking at are EGFR, BRAF, KRAS, and ERBB2. So we validated that for our diagnostic lung specimens. And then we also quantify RNA for the gene rearrangements. We perform that by NGS. We use the FusionPlex CTL on our NextSeq instrument. So we take this specimen and we split it into 2 different processes. Right now, we do 10 to 15 samples per week. These are batched, so we're only running this once a week. This is kind of an overview of the workflow. So over the course of the week, all of the samples that we have had from the previous week, we'll do a process of slide scraping, reviewing, manual TNA extraction, and then nucleic acid quantitation. We begin setup for the HS lung testing as well as CTL on NGS at the same time. Typically, HS lung, we're able to report that before the end of the week. So usually we have those results by Thursday of the same week that we started, versus NGS, which takes a little bit longer. So we don't end up reporting that until the following week, and I'll show you. So we actually report 2 separate molecular results. So we have differing workflows, right, for the gene mutations and the gene rearrangements. So in terms of reporting, we don't hold anything. We go ahead and report gene mutations first. And test setup to report time is usually 2 to 3 days for that. For the gene rearrangement report, test setup to report time is 4 to 6 days. So usually we report those on Monday of the following week. We do also have alternative testing. So if it's requested by the oncologist and the tissue specimen is adequate, then we can perform the gene mutations for our lung reflex panel using a larger 50-gene NGS panel. The test setup to report time on that is 7 to 10 days, so the turnaround time is going to be even longer there. But if the oncologist requests it, then that's what we do. So the outcomes. So in terms of our goals with all of this, one of the goals was improved turnaround times, and we actually did achieve that. So over here on the right shows you turnaround times in days from the anatomic pathology report to the final molecular report sign out, or that second report for the gene rearrangements. And so you can see in 2016, before we implemented reflex testing, our average turnaround time was 52.6 days. Some of that was send out, and some of that was using NGS in-house. Over 2017, as our hospitals came online and started doing reflex testing, we saw improvement in the turnaround times to an average of 26.5 days. And then in 2018, once we had fully implemented reflex testing and we had done several rounds of education with all of the pathologists, we did improve our turnaround times to 15.6 days, which was a pretty significant improvement in terms of turnaround time. We also saw an increased mutation detection rate. So pre-reflex, our mutation detection rate was 25.6%. In our reflex testing group, the mutation detection rate increased to 48.8%. Part of that has to do with the standardized ordering. So instead of it being a la carte, where clinicians are just ordering EGFR and ALK, instead we're ordering the entire panel, and so that increases the mutation detection rate. We also looked at the types of mutations and gene rearrangements that we were actually getting from our reflex testing panel, and the percentages of EGFR mutations that we were getting in our patient population, very similar to what had been published in the literature previously, with the usual expected mutations, and that was true across the board for all of the biomarkers that are included in the lung reflex panel. So some findings since our implementation of reflex-ordered testing for lung adenocarcinoma. We did have to add new biomarkers. So when we initially started this process, we actually used the old Oncocarta panel from Agena, and we had the old instrument with the separate nano dispenser and all of that. And so that panel was not that great for ERBB2 mutations, which we actually needed for the reflex-ordered testing. So as soon as IPLEX HS lung was available and had better coverage for ERBB2, we started that assay. And then we also got a new instrument. So we also, at some point in there, and I want to say that that was like 2019, added in track gene rearrangements, which fortunately was also on our CTL panel. Reflex-ordered testing for lung adenocarcinoma was widely adopted throughout the hospital system. And in fact, when we did a look back last year, of 721 patients with lung adenocarcinoma, new diagnosis, 93.9% of those patients did receive reflex-ordered molecular biomarker testing at the time of their diagnosis. And then we continued to see improvements in turnaround times for molecular test results for these patients. So we did a study in 2019, again looking at our turnaround times. And in that study, we had a median turnaround time of 15 days to the molecular report sign out, so small improvement, but good. And we did a study last year in 2022 where we saw a median turnaround time of 10.2 days for our gene mutation results, and that's from diagnosis to molecular report. And then a median turnaround time of 15.4 days for our gene rearrangements by NGS. So another finding that we had is that utilization of our iPlex HS lung and MassARRAY for molecular testing of gene mutations actually reduced our inconclusive and QNS rate for diagnostic lung specimens. And so these small tissue, kind of low cellularity specimens can be particularly challenging, especially when you're talking about using an NGS-based platform. And so our use of an alternative testing, our NGS-based 50-gene platform for gene mutation analysis, we actually found that we had higher rates of QNS specimens and inconclusive results using that platform. And then because we're actually doing two different workflows for our lung adenocarcinoma, part of that is based on the MassARRAY platform, part of it is based on NGS. So those same samples, same specimens for the NGS-based testing actually have a higher inconclusive and QNS rate as well. I'll show you some of the data. So our alternative testing, so we have this 50-gene panel. It was always available by oncologist request. They kind of stopped requesting it because of the inconclusive rate and that, some of their samples were not, we weren't able to result. During COVID-19, which I know was a trying time for everyone, it was for us at Methodist as well. And we had to redirect some of our technologists' effort into specific things. And so for our lung adenocarcinoma reflex panel, we did exclusively use the NGS-based testing for gene mutations for about 5 or 6 months in 2020. And during that time, I say observation from oncologists, I mean lots of complaints for increasing unacceptable, inconclusive, and QNS rates. And they were also complaining about the turnaround times. So that prompted a review during 2020 where we looked at the EGFR mutation testing outcomes for our diagnostic lung adenocarcinoma specimens. So this is just showing in 2019, we looked at 109 of our specimens, and we had an inconclusive QNS rate of 2.7%, so just 3 of the 109 specimens that we reviewed here were actually inconclusive. In 2020, when we were using the 50-gene NGS panel for the reflex ordered testing, 86 total there, 9 of those were inconclusive or QNS, so that's a rate of 10.5%. So we could see why the oncologists were complaining. In addition to that, we last year looked at our inconclusive or QNS rate for the same sample in the iPlex HS lung on the MassARRAY for the gene mutations versus the FusionPlex CTL by NGS. And just compared what is our inconclusive rate. And so you can see on the left are the gene mutations. Overall, inconclusive rate is less than 1%, versus on the right, for some of the gene rearrangements that are included in our reflex ordered panel, we get an overall inconclusive rate of about 5%. So even on the same sample, it kind of becomes obvious when you're dealing with these low cellularity, small tissue specimens. So in summary, I would say that our use of complementary technologies for molecular biomarker testing at Houston Methodist has allowed for us to implement reflex-ordered standardized testing strategies for molecular biomarkers in solid organ tumors. We've also seen improved success of molecular biomarker testing in lung adenocarcinoma specimens. It allowed us to have the flexibility to test low cellularity and small tissue specimens that are often what you get at diagnosis. And then also led to improved detection of molecular alterations in these patients. We did see improved turnaround times to molecular test results, and that allowed for timely guidance of therapeutic decision-making and improved patient care. In fact, most of our patients had molecular biomarker results before their first appointment with the oncologist. So by the time the oncologist actually met with the patient, they knew the molecular testing results and could make therapeutic decisions. So I would like to thank, obviously I don't do all of this work myself, I would like to thank the Methodist Molecular Diagnostics Laboratory staff. We have a great staff, very hardworking, and really care about the patients. The Houston Methodist Hospital and our system hospital directors who have helped us implement this reflex ordered testing and keep it going. My fellow molecular pathologists and medical directors at Methodist, so Drs. Hojat and Debbie Wally, who used to be my fellows, have actually participated in a lot of this work that we did. Randall Olson and Sejan Lee as well. All of my MGP fellows that have in some way touched this, and then our oncology colleagues as well who have been involved in our publications, Drs. Berneker, Burns, and Kaiser. And thank you.
Thank you, Dr. Thomas. I'm going to just cover some information on the MassARRAY system and tell you a little bit more about the system and how it works, and then we'll have a question and answer session. So this is the MassARRAY system itself on the left-hand side there. It's a benchtop, so standard laboratory benchtop MALDI-TOF mass spectrometry system. That's the tower on the left-hand side, coupled with a liquid handling robotic system, which is that smaller part on the right-hand side. So once up front, our chemistries utilise standard PCR-based biochemistries. That thermocycled plate then goes into the liquid handling station on the right-hand side where that blue drawer is, and it's click, walk away, completely automated data acquisition, data analysis and data reporting from that point onwards. So using MALDI-TOF mass spectrometry gives us incredible sensitivity and quantitative power. We are measuring nucleic acids and measuring them by their molecular weight and not by using a fluorophore, which means that the background is very clear. And the process of taking a measurement in a MALDI-TOF mass spectrometer only takes 3 nanoseconds. So if it's that quick, that allows us to take hundreds of measurements over the course of a few seconds for each reaction, for each sample, giving us that high level of, that extreme level of sensitivity in solid tissue panel down to 1%, and in liquid biopsy that we haven't talked about today down to 0.1%, but also that quantitative accuracy, because multiple measurements means that you can develop quantitative power and confidence intervals. So the system itself achieves targeted, actionable analysis. We heard about our lung HS, IPLEX HS lung panel today, which covers around about 70 biomarkers across 5 different genes per sample, and that's really the area that we operate in that 70 to 100 biomarkers per sample. It's highly cost effective. The cost of reagents all the way from extracted DNA through to result is less than $100 for these tissue-typed panels. And of course, we have smaller pharmacogenomics panels and others that are priced differently, but they all generally come in at less than $100 per sample. The workflow, as we heard, is around about a single day workflow. It's about a 9-hour workflow from start to finish. So you can either do it in a longer single day or across 2 days, as Houston Methodist has been doing, but achieving very rapid time to result. And we also have a variety of other applications available on the system itself. It's not just tissue oncology that we're doing. Our next session in here, and I'd invite you to stay, is all about pharmacogenetics in oncology. We've talked about sensitizing and resistance mutations in the tumour tissue itself. to determine what therapy the patient should go on to, but there's a pharmacogenetic component that we'll hear about in the next session to determine how the patient's going to respond to that therapy. We also look at inherited diseases like cystic fibrosis. We do DNA mutations, fusions and rearrangements, methylation analysis, and a variety of other applications. But in the oncology space, we have a suite of off-the-shelf panels that are used for either solid tumours or liquid biopsies. We heard about the iPlex HS lung panel, delivering that down to 1% mutant allele frequency. In the solid tissue, we have a matched ultraseq lung and an ultraseq EGFR panel for liquid biopsy if you're unable to get a tissue sample, which is sometimes the case in lung adenocarcinoma, or you want to track that patient through their therapy and see how their mutation burden is responding in the plasma. We have those ultraseq panels there that get down to 0.1% mutation frequency. Similarly in colon, 5 genes in colon, RAF, KRAS, NRAS, EGFR extracellular domain mutations, which infer resistance to EGFR blockade, as well as PIK3CA and a matching liquid biopsy panel there. And same in melanoma. Of course, BRAF in there, but a variety of other genes, KIT and others in the melanoma tissue and liquid biopsy panel. One of our other legacy panels is the OncoFocus panel. It achieves down to 10%, but it's still in use because it covers a variety of different genes. And we've recently developed the ClearSeq PIK3CA panel, a solid tissue panel with 20 clinically relevant mutations in PIK3CA, delivering down to 1%. And if what I have up there isn't what you want, we have a network of laboratories that develop custom panels. We've got around about 20 people spread across the globe. One of those laboratories is where I'm from in Australia. If you haven't picked up the accent by now, most of you would have, but also in Europe, in the US, and in China, where we day in, day out, 20 people, more than 100 years experience, develop custom assays for any set of markers that you wish for. So if it's not there, then come and talk to us because we'll make it. And in oncology, we always use short amplicon PCR, less than 100 base pairs, so that it's highly robust on that fragmented FFPE sample, as well as the liquid biopsies that are also fragmented, so that we can minimise the sample input. Our oncology panels only use between 10 and 20 nanograms of input material. And the simple reason we recommend 10 to 20 nanograms, we actually only need a couple of hundred molecules to pick up a 1% mutation, but we recognise that 90% of your sample is likely to be degraded. So unlike other technology providers out there that say 10 nanograms and gee, it'd really better be 10 nanograms and high molecular weight, we're actually making the assumption that 90% of your sample is degraded less than 100 base pairs and not available to be amplified. So it's a realistic 10 nanograms, knowing what the clinical specimen is. So with that, I would like to invite you all to come down to our booth. We've got a large number of GINA people here at this meeting. Our booth is right just inside the front door of the exhibition hall on the left-hand side there. You won't miss it. So come down and talk to us, but also taking any questions that you might have.
Thank you. That was a very interesting talk. And I have questions about, as in an earlier session where they were talking about profiling tumors even prior to surgery for selection of the correct treatment, especially if there's mutations and resistance mutations, and then looking at minimum residual disease. So I was wondering if you were using your paradigm here to do the same thing.
So we're not actually using it for minimal residual disease. We're doing just the initial diagnostic testing on this platform. However, we do get requests from the oncologists, like specifically they want to know about EGFR resistance mutations and that sort of thing. And we will use the MassARRAY to test specifically if they're looking for something. If it's beyond what's covered, which it covers almost everything that's needed in terms of resistance testing. But if it's beyond what we can do in-house, then we would have to actually send it out to get what they're requesting.
Thank you.
Yeah.
To add to that, we do have a poster at this meeting with the University Medical Centre in Groningen, which is describing a liquid biopsy first strategy, which is exactly what you're talking about there. Take the liquid biopsy at the point of imaging diagnosis and start that running whilst you're doing the tissue work, the anatomical pathology and so on. Alex, do you know what that poster number is? ST88 is the ST88, but come to the booth and I'm sure we've got copies of it down there as well.
I'm sorry if you covered this in your talk and I missed it, but how often are your oncologists ordering MDS instrument testing? When that and what are you seeing with reimbursement? Is that impacted?
So our initial testing, our reimbursement is actually quite good, especially for the gene mutation. So we haven't had a big problem with that. In terms of NGS testing, the oncologists are used to getting the reflex testing at this point. And so they usually wait until after. So they wait until either the patient has progressed or maybe we didn't detect any specific biomarkers on the lung reflex panel, and then they'll order NGS testing, larger panel, that sort of thing.
When you first started, did that take a little while?
It did. It did. I would say it took most of 2017 and part of 2018 before they really got used to the reflex ordered testing and sort of waiting for those results to come out before they started making any other decisions. We do have some clinicians who will, right off the bat, do liquid biopsy as well, because they're either aware that they didn't get a great sample during the, sort of trying to get the initial diagnostic specimen, or, that's just their preference. But I would say very few of the oncologists do that right up front. They usually wait to see what we get from the tissue first.
Dr. Thomas, great talk. Thank you. You had mentioned that you were hoping that all those diagnosed would have testing, and certainly about 94%, I think you said, did. What were the reasons for the others? Were they the usual suspects, or?
Yeah, some of it was the tissue, it was just QNS. Like, if there's no tumor in the sample that they pull, even though, they're aware from imaging or, other methodologies that the patient actually has lung adenocarcinoma, but they don't get an adequate specimen, then there's not a lot we can do. Some of it is, missed opportunity. If the pathologist actually misses ordering the reflex testing, and that kind of happened early on. So that's that study that I talked about there with the 721 patients. That was from 2017 through 2022. And so it reflects the slow adoption early on as well. But overall, I would say now our rate of testing is probably closer to 100%.
All right, well, with that, I'll say one last thank you to Dr. Thomas and to you all for attending. Please do visit the booth, talk to our staff who are all up the back there with the silver badges as you've got some time now before your next workshop. So we're available now, and enjoy the rest of the meeting.